Welcome to AETCM, the Emergency Medicine Channel. Good morning, sir. Today we'll discuss a case about a female patient with abnormal uterine bleeding. She presented with the complaint. On initial arrival, patient primary survey.
Age of the patient.
Sir, age of the patient is a 45-year-old female.
Okay.
45-year-old female came
Age
with
of the patient. Why it is important in uterine bleeding?
causation can
Causes
be
are totally different.
Yes, sir.
Okay, so you should know that.
Sir, female patient came with past history of the abnormal uterine bleeding. She has come to our emergency. So initially doing the primary survey, airway-wise patient was able to talk in one full sentence. There were no secretions in the airway. So airway was patent. Then breathing-wise, the patient's respiratory rate was 18 per minute and saturation 99%. Bilateral air entry was equal. And coming to circulation, patient's BP was 110/70 and heart rate was 98, sir. And patient peripheral pulses are palpable. At this point, we put two green cannulas and we have taken samples and sent for labs. And then disability wise, patient GCS was E4, V5, M6. Pupils were bilaterally reactive. Coming to exposure, patient's temperature was afebrile. The GRBS was 130 mg per dl, but at the same time, there were bruises over the face, black swelling
Ecchymotic patches.
Ecchymotic patches and even ecchymotic on the skin, on the forearms. So coming now to the adjuncts to the primary survey, sir. In
the ecchymotic patch is different from purpurus.
The size.
That's okay. That is that you are seeing large blood in the subcutaneous plane. That is ecchymosis. Other one is small patches. What is the major difference?
Press it.
Lab wise, what will be the major difference? Ecchymotic patches means it's a bleeding tendency. Your PT, APTT may be elevated or fibrinogen may be low. Whereas purpurus?
Purpurus, any trauma?
Purpurus are mostly low platelet, or it can be due to various other reasons for purpurus, like vasculitic purpura, age-related purpura, sunlight purpura. But most common cause is low platelet. So purpura means mostly low platelet. Whereas ecchymosis means either elevated coagulation defect, elevated PTN or elevated APTT or low fibrinogen levels. So that difference you should know. Okay.
So coming to the adjuncts to the primary survey, in the blood gas analysis, patient was having no acid-base disorder, but the hemoglobin in the blood gas analysis was showing to be low as 7.2.
Lactate?
Lactate was 4. Lactase was 2.
Slightly lactate is elevated. What is the reason for that?
Patient was having...
what happens in lactate for during anemia period?
Hypoperfusion.
Hypoperfusion. It's an effective hypoperfusion. Perfusion is there, but oxygen carrying capacity is reduced. So tissues are not getting oxygen. So body will go for anaerobic metabolism. So lactate will be slightly elevated in most of the anemia cases.
So next we sent for the labs because, at this point, and now coming to the secondary survey. Patient is a 45-year-old female, known case of diabetes mellitus since last 3 months, sir, and that is a comorbidities, but she was not on any medication as such. She was recently diagnosed as diabetes, and now the events leading her, patient had increased menstrual bleeding since last 3 days, associated with passage of clots and changing of pads 6 to 7 pads per day. With her normal, it has increased. And she first initially went to the gynecologist, where a blood picture was taken, where hemoglobin was 8.8 and WBCs were 62.2, highly elevated WBCs. And later in the hospital itself, in the outside...
When the WBC counts are elevated, what are the reasons for elevated WBC count like this? Leukemia or leukemioid reaction? What is leukemioid reaction?
Because of the infection or inflammation counts.
Some infection, chronic inflammation can produce bone marrow stimulation and counts can be elevated. But it will be never like your leukemia. It rarely crosses more than 50,000. Okay. Here it is 68,000. What is the next investigation? You'll ask when the counts are very high.
First was the peripheral.
Peripheral smear. Their blast cells will be there. Leukemioid reaction. Normally, you don't see any blast cells. Okay.
So in the hospital itself, she had one episode of syncope and fall to the head, where the ecchymotic bruise patches are present over the eye.
Okay.
And after which she was shifted to our hospital for further evaluation.
Okay.
So on initial assessment wise, primary assessment wise, patient was hemodynamically stable, and we went with CT brain plane to see if there was any bleed in the brain.
Okay.
And CT brain came normal.
Okay.
She was not having any focal neurological
Acute intracranial bleed, CT or MRI, which is superior?
CT
is always superior in acute intracranial bleed.
So the labs on the initial lab assessment evaluating the abnormal trend bleeding and the ecchymotic patches, patients was sent.
First we should have a clinical diagnosis, then only we should evaluate lab. What is your clinical diagnosis here?
Here we are suspecting a leukemia.
First of all, you have to ask what is whether she is in menstrual periods or not.
Yes, sir.
She is in menstrual periods, that may be the reason for everything. But since you have got some investigation before that, there is a chance of leukemia that can produce bleeding tendency like DIC, and that can bleed. But whatever it is, whether she is in menstrual period or not, we have to find out, because she is only 45.
Yes, she is in her menstrual period, and during her normal menses only the bleeding has aggravated.
Okay.
So we are expecting a leukemia type reaction. So we have sent for labs, and the coagulation profile was checked, for which INR was 1.42, which was elevated.
What is the platelet count here?
Platelet count was 13,000.
13,000. Okay. Why platelet counts are reduced in leukemia?
Bone marrow suppression, one of the...
Bone marrow is produced.
Only
WBCs are produced. So hemoglobin can be reduced, or platelet can be reduced, because the space is utilized only for WBC production. Okay, that may be the one of the reason. Second thing is, patient can have very large spleen that can destroy the RBCs and platelets, not WBCs. So that is also possible. Okay, whatever it is, she has got low platelet and she has got
increased
PT and INR.
Yes.
Prothrombin time is elevated. Okay.
And fibrinogen is reduced. It was only 150.
Okay, fibrinogen is reduced. It is very low, less than the expected value. Expected value is 150.
Yes.
Okay. What is the danger sign in fibrinogen levels? Dangerous level? Less than 100. Less than 100 is a dangerous level. 150 is the normal limit. Less than 150 is abnormal. Less than 1 lakh is a danger level. There you have to intervene fast. Okay. So here APTT is, PTINR is elevated, fibrinogen is low, APTT is near normal. Okay. What is DIC?
DIC
Lab wise,
DIC is defined when there is low platelets, low INR.
Platelet is actually not coming under DIC. Maybe a byproduct of DIC. 3 components. What are the 3 components? Elevated PTNR, elevated APTT, low fibrinogen. That triad produces DIC. And most of the DICs, it may be associated with low platelet. Okay. So here 2 components are there, and platelet also low. So patient can very well bleed.
And at the same time, for the peripheral smear which was done, there were 80% blast cells, and peripheral smear wise diagnosing it as APM, like your 2 myelocytic leukemia picture was there.
Okay.
Then
so what is your final diagnosis? DIC.
DIC.
How do you manage DIC in emergency room? So what is your target in when you are managing DIC?
In management of DIC, initially we have to give the cryoprecipitate. First starting with
is not the first line.
FFP.
FFP is always first line.
FFP.
How much FFP you have given? What is the dose?
We give 25
There is a dose given for FFP that you have to read. What is the dose? That is a homework for you. You have to know how much FFP has to be given. We may give 5 pints of FFP with how many we have given for this? 4 pints of FFP with
10 point cryoprecipitate.
10 cryoprecipitate. Normally 15 ml per kg body weight is the usual dose of FFP. That has to be given. Okay. Then cryoprecipitate is added to that. Okay. Why we are adding cryoprecipitate?
For the extrinsic fact.
That is for?
Extrinsic fact, coagulation factors to replenish in the body.
Okay, that FFP is enough now. Fibrinogen is there in that cryoprecipitate. That's why we are adding that. Okay. In DIC, FFP alone will not work. FFP has to be given, and along with that, you have to give cryoprecipitate also. So, what else you have to give? Here, FFP is given, cryoprecipitate is given. That is going to correct the PTNR and correct the fibrinogen level.
But the patient was also having low hemoglobin.
So, what you do?
PRBC.
PRBC. How much PRBC you have to give?
1 point will increase by 1 mg per dl. So
what is the need of giving packed RBC in this patient?
So that
what is the target level? When will you transfuse the patient?
When the HB is less than 7 in a normal.
Less than 7 only you need to transfuse. Otherwise, patient should have like conditions like myocardial infarction or ischemic heart disease, cardiac failure. Then you can give above that level. Otherwise, 7 is okay. 7 is an accepted range. Here, patient is having 7. Even if you don't transfuse RBCs here, patient will not deteriorate. Okay. Here you need more FFP and cryoprecipitate. That itself can produce volume overload in this patient because this may be a chronic anemia. We don't know whether the patient has developed acute anemia or chronic anemia. So we have to be very careful in transfusing large amount of volume to this patient. Okay. So whatever it is, you have given how many pints of FFP?
4 pints.
4 pints of FFP.
10 pint cryoprecipitate.
Then?
Because of
anemia.
1 pint PRBC.
1 pint PRBCs are given. So what that mostly that may correct your deficiencies, and you have to wait for other parameters in this patient. What are the complications of blood transfusion like this? You are giving FFP, cryoprecipitate, RBC. What are the common complications of blood transfusion in emergency room?
We can have hemolysis, febrile reaction, acute febrile.
Most common thing is febrile reaction. Patient can have fever, chills, rigors. How do you treat that?
We stop the transfusion.
Give paracetamol, chlorpheniramine. That may be enough in most of the patient. You can restart. Sometimes again patient will have problem because of restarting. So we have to be very careful. Okay, so fever is the most common thing. Then
we can suspect any transfusion related acute lung injury.
Trally.
Okay. Transfusion.
What is the difference in trally and traco?
In trally there will be the antigen antibody complexes in the lung causing the lung
trally
injury.
is like ARDS. Traco is like pulmonary
edema.
Traco is due to volume overload. Suppose the patient is having chronic anemia, he will have a compensation and more volume will be there in the body. You give blood transfusion to the patient, patient can develop pulmonary edema. You treat with Lasix, BiPAP inhalation, all these things, you can treat the patient. Whereas trally is like, it is mainly due to transfusion of FFPs and other products, not by RBC. That is common. How do you treat that? That cannot be treated with Lasix or like it may not be immediate. It may develop on next day like that. So how do you treat?
That
like ARDS. How do you treat ARDS?
High.
Initially high BiPAP with high PEEP. That is a treatment. Okay. Lasix is mainly for traco. What are the other complications of blood transfusion?
Hemolysis.
Hemolysis can occur. Immune mediated hemolysis can occur. Then
Cross match.
All blood transfusion will be cross match. Most of the blood banks will do it properly. No need to worry about that. Then the common things you see. Calcium, what happens?
Calcium.
Calcium can increase. It may not be clinically significant, but even then calcium can increase. Potassium can increase. Most of the patients will develop hyperkalemia after the stored blood transfusion because RBCs break and potassium can release. Okay. So there also your Lasix will be helpful. That's why many doctors give Lasix before the transfusion so that some fluid will be removed, some potassium will be removed. Whether they are scientifically correct or not, we don't know. But many of the doctors, they try this. Okay. We transfuse, and if the patient develops all these things, we give Lasix. Okay. but some doctors give it before transfusion so that you can avoid all these things. That has to be kept in mind. What happened to the patient afterwards?
Sir, post which the patient was taken over by hematology department in view of the acute promyelocytic leukemia, and they started with the chemotherapy of transretinoic acid.
Okay.
Further-
Anything happened after that?
After that, the patient had started developing difficulty in breathing.
Okay.
So they were suspecting like organ dysfunction as in differentiation syndrome because of chemotherapy in leukemia patient.
Okay.
Sudden,
What happened to uric acid in all these cases?
it should increase.
Normally it may increase even after your chemotherapy also it can increase. Okay, hyperuricemia can occur. In that type of hyperuricemia, what is the treatment of choice?
Yes. Fluids.
Fluids are given to prevent renal injury. What is the drug of choice? Rasburicase.
Yes.
Okay, normally we give, before that we give other drugs to prevent the high uric acid, febuxostat, all these things. But once the patient come to emergency room like tumor lysis syndrome, you have to give rasburicase. That's a anti-uric acid drug that can be given in that condition. Okay. Thank you.
Thank you.